involved in a lawsuit. So I want to start with that this presentation is not considered legal advice. This is just to help you in your practice, finesse your documentation in a way that will be beneficial, and it will allow your patients to feel comfortable when they are reading your documentation. So today we're going to look at the challenges with documentation. We're going to review frequent allegations that are made against case managers. You're going to be able to recognize the liabilities that are associated with incomplete documentation. I'm going to also tie in some principles of respect for patient rights and dignity, along with your, for your objectivity with your documenting that aligns with principles 2 and 3. And then really the goal is for you to document your patient interactions objectively, accurately, and concisely. So let's start with that the medical record is a legal document. Is required by state law for patients' past, current, and future health issues, mental health issues, and really the purpose is for you to memorialize the care that's rendered. But with the medical record, especially now that everything's electronic and it's kept forever, whatever you document follows that patient forever. So let's look at some objectives for documenting. Right? You record the services that you provide. It's the who, what, when, why, and how. And it really facilitates communication of patient information across the entire care team. It's where you document patient details, the narratives, treatment plans, thought process. When it's done well, it demonstrates a high level of quality of care. It shows why care was provided, and it can be a protection from liability. You have reimbursement. You can't bill for what isn't documented. And then of course, there's a myriad of, there's so much data out there that can be captured for regulatory and licensing, quality performance, clinical research, your third-party payers. All of that data is used some way, and I'm sure there's a lot more ways that people are collecting data behind the scenes. But there's documentation challenges, right? Depending on your place of employment, patient load may fluctuate. But right now, especially in the acute care settings, patients, as you know, there are no beds, right? Long-term care, skilled care, all of those places, they don't have the staffing, they're shutting down. And so patients are being housed in acute care beds for a very long time. And so as a case manager, you're having to still try and find placements. So your load may grow because you're still taking care of those acute patients as well. But patients are also sicker. They require more coordination of care. It can make it difficult to communicate and document timely. Then we look at the electronic medical record. Now, I've worked with Cerner and I've worked with Epic, but I know that there are other healthcare medical records out there, but there is rarely one place to document something. And usually when you're onboarded, you're shown what the medical record is capable of, but rarely where it should be documented. And so it can be difficult to find information if people aren't documenting in the same spot. And then depending on your level of access, you may not have all of the information. So as a risk manager, I go in and I do chart reviews, and I may have a director, actually this happened in a peri-op setting. I had the director of the OR, I had the director of quality, I had a quality coordinator, and nobody could see the timeout form. It took getting a frontline nurse to come in and log in, and her view was very different than all 3 of the other views. So as a case manager, you may have a view that is different than the rest of the healthcare team. So never assume that somebody's going to be able to see what you've documented. Then many regard documentation as burdensome, feels like it takes time away from the patient. Now, from a case management perspective, right, you recognize that your documentation supports whether or not the patient gets the care and the services that they need, but when you're a frontline person, you're trying to stay above water and take care of the patient, but you might not recognize that your documentation can really protect the patient. The documentation is critical for communication and decision-making. And like I said in the beginning, one error can set off a chain reaction of incorrect treatment decisions. Now, I want to talk about the Cures Act and open notes, because this is what I think been the catalyst for me giving this presentation across our book of business on a regular basis. I'm embedded into nurse residency programs, the medical grand rounds and things like that. So on April 5th, 2021, the 21st Century Cures Act went into effect. And that gave patients the right to immediate electronic access of their medical record. So on the inpatient side, this was a huge shift. Patients could be reading their notes while they're in the bed and being cared for the provider who actually wrote the note. Then as of October 6, 2022, patients now have access to all of the information that's afforded under HIPAA. So on the outpatient setting, telephone notes historically hadn't been visible to the patient. And now all of a sudden patients can see it. And patients are reading things and they're catching errors. They're finding things, those templates that pre-populate, they're finding health assessments that are documented when the provider never even assessed their abdomen or listened to their lungs or did a complete physical assessment. And so they're calling, they're angry about what they are considering fraud. So this is a big deal, and how you document can really make the patient feel like you didn't provide the best care because you were biased against them. So we're going to talk about how your documentation can be done in such a way that it's not going to send the patient into an angry frenzy looking for an attorney to seek a lawsuit. So if you provide direct patient care, you face the risk of being named in a malpractice suit. So the question is, could you defend yourself against medical negligence with your medical record documentation alone? Because when a patient claims that they've been harmed, one of the first things that will be taken is to review the documentation in the medical record. So when we talk about defensible documentation, all that means is that the medical record should show that you acted reasonably within the current standards of care and that your performance was according to the policies and procedures of your institution. It doesn't mean, when you think back to defensible medicine, right? When providers would order unnecessary tests, that they would do a full workup and it was costing our spending, right? Our healthcare spending just ballooned because providers were trying to protect themselves by testing for everything and anything. That's not what we're talking about with defensible documentation. We're talking that it should just reflect the standard of care and that your policies and procedures were followed. So when we talk about medical standard of care, this is the type and level of care that an ordinary prudent healthcare professional with the same training and experience would provide under similar circumstances. So the critical question in a medical malpractice case, would an equally skilled case manager have provided the same treatment under the same or similar circumstances? When I was reading up on case management, because I'm not a case manager, it was interesting when they were talking about ethical decision-making and boundaries and things, would whatever's happening in your client relationship, patient relationship, be an embarrassment if it was published in the paper? If it's questionable, then you have to sit back and wonder if you are, really outside of your scope of what you should be performing. And so the same thing is here. Your standard of care, when they're going to ask, would another case manager have behaved in the same way, made the same decisions? Now, the American Case Management Association, so this is an example of standards. So they have national standards for transitions of care that are applicable across the whole care continuum. So standard 1, identify patients at risk for poor transitions. Standard 2, complete a comprehensive transition assessment. Standard 3, perform and communicate a medication reconciliation. Standard 4, establish a dynamic care management plan that addresses all settings throughout the continuum of care. Standard 5, communicate essential care transitions to key stakeholders across the continuum. So when we talk about professional negligence, that is simply when you fail to provide the standard of care to a patient that results in injury or damage. So you may wonder, can they sue me? What is it that, what do they have to prove to sue me? there are 4 elements of a lawsuit: duty, breach, injury, and causation. So in a lawsuit alleging professional negligence, the plaintiff, which could be the patient or their family, has the burden of proof. And that means for them to win, they must prove that there was a duty to them that existed, right? And that's established when you take on the care of the patient. The standard of care was breached. So that could be either you did something that that you shouldn't have, or you didn't do something that you should have. Then the patient was injured. So what happened to the patient? And that injury has to be caused by the breach in the standard of care. So if you didn't do something and it resulted in injury to the patient because of what you didn't do, then they have something to, they can prove that there was negligence on your behalf. Now I want to transition for a minute and talk about memory, because memory fades with time no matter how significant the events are at the time. And so you can look at this study, Ebbinghaus's curve of forgetting. In under an hour, you are only recalling about 60% of what happened. So think about the timing of your documentation. You know, do you do your documentation real time when you're with the patient in the room at the time? Or maybe later in the shift, you take notes and then add to it later. You know, I'm sure that you have seen physician documentation, progress notes, history and physicals, operative notes, things that are dictated, you know, sometimes days or even weeks after something's happened, and it handicaps the next person who's caring for them. But there's risks to waiting to document. You may get distracted. You may forget some important pieces in there that could impact the care that is rendered by others or decision-making of others. There could be an adverse event, and without the documentation, there's nothing to show what happened up until the patient took a turn for the worse. You really should know your organization's policy on documentation, because that is what you're going to be held to. If you have a policy that says that you should document A, B, C, and D, and you only do A, B, and C, and a plaintiff's attorney can show that you also should have been documenting D, then he's going to be able, or they'll be able to portray your documentation and your care in an unflattering way. So, reason why I want to talk about memory is because if there is a claim, it can take a long time from when you provided care to when you might have to give testimony in court. So if you've ever been sued, I'm sure that you've had trouble or it's been challenging to recall something precisely and could. But if you haven't, just think back to last Tuesday. What were you wearing? You know, what did you have for breakfast or a snack? You know, those little nuances that you just don't think about. So when we're talking about memory versus times elapsed, there can be a big gap. So many states have tort reform, and this is to prevent frivolous claims from going forward. So it's a layer that a plaintiff's attorney has to take before they can bring a case to court. So Maine has what's called a panel process, and this panel process can take 18 to 22 months to conclude. And all of this time frame was pre-COVID. So I'm sure it's even longer now because the courts are just getting into the swing of things, and they're bringing things that have been kind of in the wings waiting. New Hampshire has a screening panel, and they encourage a resolution of the dispute before trial, but they want to conduct a hearing within 6 months of that being filed. Vermont requires a certificate of merit. So a plaintiff's attorney needs to swear under oath that they have consulted with an expert and that there is merit to this case. And then Massachusetts has a 3-person tribunal, and the plaintiff's attorney must make an offer of proof. So with the statute of limitations, tort reform, in a trial, it can take 5 to 7 years for a claim to resolve. And that's for your adult patient. Pediatric statute of limitations can be even longer. So if you even look at the 5 to 7 years, you could potentially have no independent memory of an event that took years prior, because memory fades over time. But let's say that you have a wonderful memory. You are top notch. You can recall everything. If you have a plaintiff who has visible damages sitting there and you are telling a jury, well, I always do this. And yeah, I know I didn't document it and I know it resulted in harm, but I know I did this because that's what I always do. A jury's going to place more merit in a patient with visible damages and poor documentation than they are on you being an expert person in your memory. So keep that in mind. Now, a defense attorney, which is your attorney, wants to use documentation to show that it was medically appropriate, that you performed it within a timely manner, and that it was within the standards of care applicable at the time of the incident. And that's key, right? Standards of care changes over time. So it's not like you're going to be held to today's standards for something 5 years ago. Now, know that your good documentation could be the factor that dissuades a plaintiff's attorney from even taking the case. So we're noticing nationally that there is a decrease in the number of claims being made. And plaintiffs' attorneys are looking, they're only going to take cases that they think they can win. And so they're being a lot choosier in what they take. But what we are seeing nationally as well is cases are settling for a significantly higher amount. What used to settle for maybe 1 million might be getting 20 or 50 million. You know, I recently read about a case that settled for 100 million or was awarded 100 million. That wasn't something that you heard about 20 years ago. So keep that in mind. Now, a plaintiff's attorney, which is the patient or their family, wants to use poor documentation to discredit you, prove that your care was outside the acceptable standards, show it was untimely or absent. So when they're looking to bring a professional negligence case, they're going to look for red flags in the record. They ask for the medical record and they're going to comb through it. They're going to look for things such as a delay, substandard or inappropriate treatment. They're going to look for charting inconsistencies, lack of patient teaching, battles between healthcare providers, lack of informed consents, late entries that aren't documented as such, comments that appear to be self-serving, or even comments that sound like you might have been biased against the patient. Now let's talk about some common allegations against case managers. So it's good to know about the common allegations and how they might happen, because that gives yourself a way to kind of protect yourself, right? You can know where the potential gaps are, and you can help make sure that you fill those. So we have delays in advocacy, right? So delays in advocacy can cause delays and in care, and it can affect the patient's outcome. Then you have clients' lack of self-determination and autonomy. You know, it can really be difficult to know at what point in your case management process to intervene, especially if that intervention is going to result in a restriction of a client's desires. One of the examples that I had read about was, you know, a patient who really shouldn't be driving anymore. You know, their primary care provider hasn't done anything. You know that they're still driving, but they're at risk of harm to a third party. You have a duty to talk to their care provider and help facilitate that, but that can make patients angry, right? They can become very upset when their autonomy is removed. Denial decisions, you know, that could be a result of a poor assessment, poor documentation, not having that information to support the care that's really needed. Non-adherence to your organization's policies or procedures. So make sure you know what those are. You know, when you deviate from those, it gives a plaintiff's attorney the latitude to portray your care in an unflattering way. The other thing to keep in mind is, even though national standards exist over here, sometimes organizations will have the policy be much stricter than what the national standard is. I know this has nothing to do with case management, but it's a good example. An emergency C-section, right? The decision to incision national standard is 30 minutes. I had an organization whose policy said 10 minutes. Well, now if harm happens and that baby has a bad outcome, and it was outside of, let's say it was 15 minutes, it was outside of their policy of 10 minutes, nationally, they were still 15 minutes within that standard, but because the organization's policy was 10 minutes, that's the standard that they're going to be held to. So know your policies and procedures of your organization. Unsafe transitions, right? We know transitions of care are a dangerous time for patients. It hinges so much on communication, and so much information is handed off and important stuff can be buried. So it's really important for, case managers are integral to those safe transitions. And then inadequate comprehensive assessment. An incomplete comprehensive assessment can lead to unsafe transitions, denial decisions, poor patient outcomes. And then, the case management process starts with the assessment. So if this is lacking, then the planning, implementation, and coordination could be flawed and leave the patient with a less than desirable outcome. So let's talk about some documentation risks. There are definitely potential pitfalls with the EHR. The first is allowing tasks to be closed without requiring action. If there's something in the medical record that you should be doing, you should not be closing out that task without documenting why something wasn't done. If you get an alert in the medical record, know that that is time-stamped, and it is somebody is able to see how much time you spent reading that alert. It's time-stamped from when it was opened and when it was closed, and sometimes we're talking like a second. It's very hard to defend that you made a decision to close that alert based on the patient's status. If you are not carrying out a task, there should be a notation why. Some places still have multiple systems that require duplicate documentation. Anytime that you are duplicating your documentation is problematic. It could be, because you could have conflictions in what you've actually documented. You could have conflicting times that raises the question of which one was it. Relying too much on electronic communication at the expense of face-to-face. As I had said earlier, information isn't always found in the EMR, and depending on your level of access, they may not even be of you. Recently, I had a case where a anesthesiologist had written a note regarding, post-op instructions, and they've been using this field for a year. And unfortunately, this one time, harm reached a patient. The nurse didn't see it. Care was rendered. They weren't notified of something. And the anesthesiologist had no idea that that was a field used at one of the other facilities and not at the health system at the organization they currently were at. And, all those other times, it was only luck that it hadn't reached the patient. This time it had. So if it's important, make sure that you're communicating urgent matters directly to the people who are providing care. Common documentation errors. So here's some things that we find when we're doing chart audits. First, not documenting, right? You think that you're going to get to it later, but things get busy and you completely forget about it. And when I was at the bedside, I used to do that. I'd get home and I'd be like, oh crap, I forgot to document this. And I'd have to call up and ask somebody, to document by proxy, and then I would sign it when I got in. Sometimes late entries can't be avoided though. But when you do have a late entry, make sure that you're documenting it as such. Your organization should have a documentation policy that would outline what it is that you need to have documented. Not documenting thoroughly. Some people are pretty savvy at shorthand and just typing up the bare minimum, but it could leave the room for interpretation. It could miss important elements. Depending on, some EMRs allow you to have multiple charts open at a time. You could document on the wrong one, or you may even confuse one patient from another. If you're taking notes throughout the day and you're sitting down to document, and you've got 8 patients that you have notes on, you may confuse them in the medical record. So even when you remove that charting error, it's still going to show in the medical record. It'll just be lined out, but when they print it and submit it for court, it's going to show that you had documented on another patient and removed it. Paper documents, forgetting to date and time and entry. If there is a date, signature, and time stamp on your paper document, it should be signed and filled out. Now, if any of you document, not document, but dictate, really dictate timely. Timely dictation is essential for patient care and for those who are caring for patients after you have left. This is really big, though, with surgical reports, things that, physicians who are handing off, when those dictated reports are unavailable and it results in patient harm, it's very difficult to defend. If you do use dictation, or if your organization does and you see that they use a do not use, a dictated but not read stamp, bring that to your risk manager's attention, because even though some think that this is going to reduce their liability, it actually increases it. Because in addition to saying that the inaccuracies caused harm, then they're going to tell the jury that the provider was too busy to worry about the accuracy of the note and too unconcerned about the patient's safety to make sure that it was accurate. So that's not going to be helpful to them. And that's not the same as dictated using voice recognition software or things like that, but this is the dictated not read stamp. We do not recommend it. All right, let's talk about some copy and paste. So there are benefits, right? You are able to capture complex information that doesn't readily change, the patient's history, things like that. But there are risks because that copy and paste function, especially if you're not verifying that information is accurate, can be perpetuated months, sometimes years. So the other piece is that a lot of people will pull in information, and so important information is buried within a bunch of information that is redundant or unnecessary, and it can really create medical records that are inconsistent and lack credibility. So you are responsible for the content of your documentation, whether it's original or copied and pasted. And we really recommend that if you are copying and pasting a patient's history from a physician's HMP or some other document that you didn't verify that information, because more times than not, there is an inconsistency in there, and you will just perpetuate that if you copy and paste it. Review your notes for accuracy, completeness, and relevance. Make sure that if you are copying a previous note, that you are modifying it to reflect the patient's current status. I've seen a lot where, you're waiting for a test result or something's unavailable at this time, and then that note's copied and pasted through the entire stay. And that can look fraudulent. It can look sloppy, like you really didn't assess the patient. And then you want to make sure that you exclude unnecessary or redundant information. So try to keep it as clear and concise as possible when you're documenting, so it is useful, right? Who wants to read a 3-page note if you can do it in 2 paragraphs? So there's benefits to being clear and concise and removing that redundancy. Let's talk about documenting noncompliance. Noncompliant is simply not following the plan of care. Explore why first, right? Is it the patient's comprehension? What is their literacy level, their health literacy? Why is it that they're refusing? Is it that they maybe can't do something on a Tuesday because they have a loved one that they care for or need to transport? Maybe they don't have transportation. They might not even understand the importance and level of urgency for following a specific treatment. So instead, describe what makes the patient non-compliant. As a healthcare provider, it's your job to make sure the patient and family understands the risks of not following a recommended treatment. And if after they're informed and they still don't want to pursue the recommendation, then they're making a shared decision, right? That's part of their care. That's part of their right. And if you document that, if there's an allegation of negligence, but you have done your best to explain the risks and benefits and the level of urgency, and they understand and you documented that, then they're really not going to have a leg to stand on, even if their condition worsens because they didn't choose to have that treatment. So here's an example of documenting noncompliance, right? Patient refuses to take his pills. Well, it's better to document that the patient has been non-adherent to therapy, or maybe the patient has difficulty tolerating, or patient has difficulty affording. But find out why, because then you can tailor what the patient needs to help them become compliant with that medication. Some documentation don'ts. Don't make derogatory comments. Frequent flyer, non-compliant, or drug seeker. Because when you use derogatory comments, these suggest that you didn't provide the patient with the same level of care that maybe you gave other patients. I remember being at the bedside and having that patient who was just mean, right? There was no psychiatric reason. There was no cognitive deficits. They were just mean. Their family was tough to deal with. And then you had that sweet little old lady who didn't have any family, who was appreciative, right? So, but when you make comments in the record, it could demonstrate that you maybe were a little bit biased against this one because, you know what, they were tough to take care of. You didn't want to be in there. So be careful how you document your interactions. Avoid making self-serving statements. Now, we all have a form of self-serving bias where we like to take credit for positive events, but we like to blame outside factors for negative events. So the same thing could happen if there's a bad outcome or some other thing that happens with the patient where you might blame that outside factor or the patient's decision for their poor outcome versus just having it objective. You want to avoid altering the record after an event. So let's say something happens to the patient and you go back and you look through the record and you see you missed something important. You don't want to change documentation from adding to a previous note, an addendum that might elaborate or clarify your involvement or anything like that, because it can really compromise the integrity of the medical record and make it difficult to defend. Now let's look at some, possibly judgmental wording. And these are from the Open Notes website. So highly anxious drug abusing patient. Instead, right, patient uses injection drugs, right? You don't want to label them as their disease or something like that. Now, avoid using, if there's a diagnosis of anxiety, then that's fine, but don't use it in a way that sounds judgmental, right? When writing entries, you want to use language that's specific rather than generalized or vague. You don't want to speculate when documenting. The record should always reflect factual information, what is known versus what is thought or presumed, and be written using factual language. So rather than documenting wound looks good, document what you observe. The incision is healing, no redness, no signs of infection. Or, patient appears to be comfortable. It's better to document patient alert, conversant, calm, denies pain. One of my favorites was, when I'm talking to nurses is patient appears to be sleeping. I used to write that all the time, but the next time you round, the patient's dead. So had they appeared to be, were they breathing when they appeared to be sleeping? So it was better to document that the patient's resting with eyes closed, respirations regular and unlabored, because then you can at least demonstrate they were breathing when you went into the room. So documenting difficult encounters. It can be challenging to document things, topics such as mental health, obesity, substance use, physical abuse, driving privileges, maybe even documenting visits with potentially litigious patients. Those patients say, I'm going to call my attorney. Maybe it's a patient who has a suspicion of a life-threatening illness. So, as you're documenting, pause and reflect. Try to remove any emotion from your documentation. If, like, let's say that the patient is angry and threatening and just really difficult to deal with, run it by another person first. Make sure that what you are documenting is factual. You can quote versus summarizing and then describe the behavior. You want to describe the behavior rather than labeling the patient or making judgments. Now, jousting. These are criticisms written in the medical record that are voiced to patients or by subsequent providers that insinuates that something bad happened and that there was an untoward outcome. The medical record should only contain documentation that pertains to the factual and objective information about the direct care of the patient. It should be free from jousting statements that blame, accuse, or compromise other caregivers, the patient, or their family. The record should not be used to voice complaints about the department, about other providers or another facility. There shouldn't be any documentation about fights between disciplines, any staffing issues, vendor issues. None of that belongs in the medical record. So some examples might be, saying, directly to the patient or their family, gosh, you should take legal action against that provider. Or saying something like, eesh, that's not what I would have done. Or maybe you have a look of surprise or horror when a patient mentions something about a previous care. I'm sure if you've been in healthcare for any length of time, you've probably seen it written in the record where it just makes you cringe. So here's a jousting example. The GI service refuses to scope the patient. Instead, you could write continued discussion with GI about endoscopy timing. Same thing about the insurance. If you're trying to get something approved, instead of saying that the insurance company is being ridiculous or whatever, you can say continue discussion with insurance about, whatever it is that you're submitting. Keep in mind that the medical record is not a place for you to vent. Even if you're tired, frustrated, and you've just had it, try to remove that from your documentation. Tips to avoid jousting: listen objectively and don't jump to conclusions, right? Patients can distort and embellish information about their past medical experiences. And I'm sure you've had where as they begin to ruminate on what's happened, they become angrier and it becomes their new truth, right? It becomes, they believe what they are saying actually happened. So just watch your body language. Imagine yourself as the other provider. So if you are about to say something about the care that someone else has provided, think about how you would feel if they said about you what you're about ready to say about them. And then limit your charting to the care you are providing. Do not comment on the care of others in the record, and that will help you prevent jousting. So I had a nurse ask once, she felt that a wound vac had been inappropriately applied. And because of that, the wound was worse. And she wanted to know how to document that. And my recommendation was that she would document the removal of the wound vac, how many sponges she took out, the condition of the wound, how many sponges were reinserted, the application of the wound vac, how the patient tolerated it, and who she notified. You don't know what has happened from the last time something was applied to now. And the same thing, you don't know how the patient might have presented or their issue when they went to the emergency department last week. So just don't comment on the care of others and you will go a long way to avoid jousting. Now, let's say it's a provider that you wouldn't let take care of your dog and you feel like you want to add validation to the patient. Keep in mind that if they believe that that somebody did something wrong and they go seek a plaintiff's attorney, they may have you deposed to testify on their behalf. So you could lose a week of your life because you didn't remain objective and avoid jousting. So if anything, do it to protect yourself and not have to go to court. Message system. So I know for Epic, they have an Epic chat that is not part of the medical record. So if you are using any type of medical record chat, find out if it is part of the permanent medical record. Because if you're using it to notify a provider of a patient's condition, then if it's not part of the medical record, then you still need to document that in the medical record. You don't want to copy and paste a chat session, because if it's not part of the medical record, the other party isn't thinking it is. So the way that things are worded could be problematic. So just do a summary. But if this is the message system that is part of the medical record, avoid using too many abbreviations. Many organizations have an approved abbreviations list. You want to avoid the use of chat speak. Don't forget that the message is a permanent legal document. You don't want to alter the complete documentation, and you don't want to play message ping pong. I've seen this with, billing on an outpatient setting where, hey, how are you? How's your weekend? Tag your it. That's not supposed to be in the medical record, and it doesn't belong in there. So factual. Let's talk about documenting incidents in the record. So incidents do need to be documented in the medical record. So it needs to be documented. Let's say you walk into a patient's room and you find them on the floor. You would want to document what time you found them, where they were, how they appeared, the patient's response to the event, any evidence of injury, any, who was notified, any interventions that were done, and then the patient's response to those interventions. You want to avoid using words that expresses an opinion. Instead, document only facts. So if you find the patient on the floor, patient was found on floor. Don't comment that they fell out of bed. If the patient states that they did, you could say patient stated they fell out of the bed, but don't say that they did. Avoid certain terms such as by mistake, accidentally, or miscalculated, because those conjure up images of errors and compromise patient safety. Documenting an adverse event. It should never be, you don't want to speculate, on what happened, or document it as a medical error or attribute blame. What we had talked about altering the record. Also never document that you have notified risk management or a malpractice carrier. Never refer to an event report. So if you have event reporting, and let's say you are providing care and you catch something before it reached the patient. Maybe it was in multidisciplinary rounds and you guys identified a near miss, something that had it reached the patient, it could have caused significant harm. You want to put that into an event report because they can't fix something that they don't know. So use event reporting to document those types of things. But when you refer to an event report in the medical record, now a plaintiff's attorney can say, oh, something happened. I want that event report brought into the court. I want it submissible. And event reports are protected. They're protected so organizations can freely investigate on what the problem was and then put things into place to prevent it from happening. Because when they're not protected, then the old, probably if any of you have been in healthcare a long time ago, I mean, even 10, 15 years ago, right? The culture was a lot different. It was that deny and defend and, let's not talk about it. But now it's a much more transparent environment where you're looking at systems and how you can fix things and less on an individual or an isolated event. But that's the outcome of having documents like event reports protected so organizations can be proactive and fix things. Now let's talk about guiding principles for documenting patient care. The most important reason for you to maintain accurate, credible medical records is that good documentation protects your patients. That's the bottom line. Court stuff aside, your documentation, if it's done well, can protect your patients, because when there is weaknesses in charting, it increases the margin for error that could result in patient injury. Now let's talk about best practices. These are these are the policies and procedures of your organizations. That's the standards that you will be held to. So know them. Now we're going to take a more in-depth look at the ACMA national standards for transitions of care. So standard 1, right? Identify patients at risk for poor transitions. So you should be screening for medical, behavioral, and social factors that are associated with high risk for poor transitions. You want to look at frequent facility admissions or inappropriate utilization of healthcare resources. Is there polypharmacy or poor medication adherence? Do they have multiple comorbidities or two or more chronic conditions? Is there a cognitive or functional impairments? Are there behavioral health issues? What are their social determinants of health? And the World Health Organization defines social determinants of health as conditions in which people are born, grow, live, work, and age. And these conditions include things like financial and economic limitations, poor health literacy, housing, food instability, lack of social support, unreliable transportation, and unhealthy behaviors. Standard 2, complete a comprehensive transition assessment. So there should be a review of relevant healthcare utilization across all care settings, including, look at recent provider orders, payer benefits, preferred networks, claims data when it's available. Assess their self-management abilities. How are they with their activities of daily living or instrumental activities of daily living? What's their decision-making ability? What's their willingness to participate in their care planning discussions? There should be a completion of a med reconciliation and a review of patients' medication adherence. Review and document the patient's care goals, and when appropriate, identify the patient's designated decision maker. You want to examine the advanced care planning documents. Make sure that they're current, complete, and available to the entire healthcare team. And then you want to make sure that at that transition, you're communicating an assessment summary to that next care setting. So standard 3, perform and communicate a med reconciliation. Med reconciliation is such a tough area to be thorough and credible. There's so many places that you could find the information. So to compile a full medication history, you want to make sure that it includes both prescribed and non-prescribed, right? Those over-the-counter medications. Now you have to include, marijuana use, and because that can affect many of their medications, or even if they have to go to the OR and they need anesthesia. But you're going to look at all available sources, right? The EHR, so look at previous discharge summaries, e-prescribing records, paper records if there's any, self-reported from the patient or caregiver. Ask them to bring in that brown bag of all their medications. You may find that they have, 2 of the same medication, just one is like Lasix and the other one's furosemide, or, it's amazing when they bring in all of their medications on what you find. Calling the patient's pharmacy and making sure that if they use a local pharmacy and maybe they have a mail order pharmacy, right? Their PCP. Identify patients who may be at high risk for medication-related adverse events or non-adherence because they have too many medications or they are on opioids. Maybe some of the medications they have are high cost or specialty drugs and they have trouble accessing them. Verify that the medication list is accurate with the patient or caregiver. When I've seen where people are going through the list in the medical record and they're like, are you still taking metoprolol 50 milligrams? Are you still taking the, Nuvolog insulin? And patients are like, yep. Instead, tell me what you take for your diabetes. Tell me what you take for your high blood pressure. That gives them, they have to talk about it, right? They're not just going through yes. They have to actually go through and tell you what they're taking. Verify their medication adherence. Are they actually taking the medications as prescribed? Maybe they have access barriers. Maybe they can't afford it, but they don't want to tell you that they're not taking it. And then make sure to document all of the med reconciliation activities in the medical record. If it's incomplete, finding a way to document that it's not complete, because one of the things that happens are the medication reconciliation is incomplete. And so things aren't continued while they're in the hospital. And some medications have black box warnings that they can't be stopped. They can't, or patients, it's documented that the patient's taking it, they really haven't been taking it, and all of a sudden you're resuming medications in the hospital that patients haven't been taking for months. So, this is a big deal. Standard 4, establish a dynamic care management plan that addresses all settings throughout the continuum of care. So, if you're in the acute care setting, obviously it's going to be right there, but you're still coordinating with home health or long-term care or skilled care and trying to make those transitions. So this care plan should be created with input from the patient, the primary caregiver, family, and it should be available throughout the continuum, right? We know that medical records don't talk to each other. This is a very hard thing for healthcare to accomplish. That's probably why we have so many bad outcomes, because our transitions of care are so broken. So some suggested documentation would be pharmacy consults as appropriate. Do you have a process that you are putting in a consult for pharmacy if they're on 10 or more medications? Or if they come in with a specific, maybe they're coming in with DKA and you want to have a look at their diabetic medications or what they're doing. Documentation of evidence of patient and family or caregiver awareness and understanding of what needs to happen. There should be evidence of timely reassessments as the patient moves across the care settings. There should be documentation, right, of referrals and linkages to community resources and services. There should be documentation of patient and support network agreements to referrals. There should be supporting documentation that services and referrals meet the expectations and requirements of the payers. So there's a lot of documentation that is needed as a care manager or case manager that supports the patient's next steps, that supports those transitions. And then standard 5, communicating essential care transition information to key stakeholders. So you should be documenting both clinical and social determinants of health, things like the diagnosis, comorbidities, chronic conditions, medications, known history of adherence, any potential for polypharmacy, opioid or substance abuse, any labs or other tests, appointments, cognitive or functional impairments, any behavioral health issues should be documented across the care continuum, but done in a way that is objective and non-judgmental. So how to document? Chart the facts and avoid the use of personal opinions when documenting. And if you take away anything, avoiding the use of personal opinions will help you in your documentation practice 100 times. By documenting what can be seen, heard, touched, and smelled, your entries will be specific and objective. Describe signs and symptoms. Use quotation marks to quote the patient and document the patient's response to care. So be thorough. What you didn't do or assess, why you didn't. What you taught, who you called, and what they recommended. So here's an example on how you can change judgmental to objective. So here you have patient is paranoid but refuses to acknowledge it. Instead, you can write, patient states, there is a transmitter in my tooth, it talks to me. Simple quotes without judgment can be effective. Same thing with, I was recently talking with one of my organizations, and they said that they're having problems with nurses documenting, that when there's like a custody battle or things like that, that they're documenting that the other parent, is abusing the child or neglecting the child, instead of saying parent states that the other parent is abusing the child and that they're bringing in DHS. It sounds like it's factual the way that they're documenting, but instead they really should be documenting that the the parent states or the patient states and what it is. So then it's objective. When documenting, you want to use correct spelling and grammar. Sloppy documentation can be inferred by a jury as sloppy care. Use caution with abbreviations. If you have a paper document, fill in all the blanks. If it's not applicable, NA, lines, document as close to real time as possible, and know how to correct or clarify your entries per your organization's policy. So here's one, when we talk about abbreviations. SOB means something very different to us in healthcare than it does to a patient or their family. So instead of saying patient was SOB, FU next appointment, instead spell it out. Patient was short of breath, follow up at next appointment is more objective, and it doesn't leave room for interpretation. Documenting an addendum. This is one area that I like to cover because it can be problematic depending on when it is done or why it's done. So it should only be used for the facts or clarifying information, vital signs, diagnosis, assessments, or the correction of facts, right? The persons involved, time of event, sequence of events. It should not be used to state opinions or perceptions or defenses. So the major argument against an addendum is that it has the potential to be perceived as an attempt to falsify the record. So if it is done after you find out that the patient had an adverse outcome, whether it was a delayed diagnosis or some other thing was missed, you don't want to go back in and do an addendum because it can be perceived that you are trying to change the record, and then it can make it difficult to defend. Documenting provider notification. It should have the provider's name, the exact time of the call, specific information that was provided, include any orders given or not given, what warrants a callback or any interventions. But the same thing goes if you make a call to a payer or to some other type of referral or things like that. That should all be documented in there on who you spoke with, not just the company, but who did you physically speak with, because that's the person who's responsible for whatever decision they've made or whatever thing that they've told you. So complete documentation. So for case management, your observations and assessments should be thoroughly documented. Any ongoing monitoring, your evaluation findings, any interventions and the patient's response, the patient's progress with current treatments and any modifications to the case management plan, and include rationales for those changes. Your discharge planning should be complete and starts on admission with your comprehensive assessment. The plan of care should also include documentation of the patient and family agreement, all patient and family education, including any barriers, all outcomes, and then evidence of continuation of care after the discharge from the inpatient setting. How was the transition? Was there a complete handoff? If the patient's readmitted, is there an evaluation of what happened and a look back to see if something could have been done differently? Informed consent. Pre-certification for procedures and follow-up if insurance denies the request. Make sure that there's documentation of advanced directives. So in addition, all communication with the following must be documented. So if you communicate with the patient, their family, the insurer or payer, any vendors, and all other healthcare providers inside and outside of the organization. If it pertains to the patient and their care, it should be documented. However, if you disagree with, let's say you think the patient should have specific care and you don't agree with the provider, your organization should have a chain of command policy where you can escalate something, but you wouldn't want to document that you feel like the patient isn't providing the right care to the patient and or anything like that, because that doesn't add value. You want to escalate it and be the advocate for the patient that's needed. Now, when we're talking about informed consent, CRICO, which is part of the Harvard Medical Group, releases a benchmark report, and they released that absent or insufficient documentation of informed consent increases the chances of a malpractice case closing with an indemnity payment. So this is payment to the patient for the negligence. So when we're talking about informed consent, right, people think a signed informed consent is evidence of a patient's consent to a procedure or whatever it is. But those consent forms are lengthy. They're not written at a 5th grade reading level. A lot of times they're written by attorneys and they're 4 or 5 pages long. And so juries believe and litigants claim that patients didn't understand those lengthy forms. So there really should be a discussion written in the medical record, right? So the fact that there was a discussion that was had, so providers should have it in their progress notes. If you're going over something, you know, document the conversation that you had. If for some reason they don't want to have a treatment, and like I said earlier, you know, you document that the risks of not having the treatment, the level of urgency, that informed refusal shows that you partnered with the patient. And if it's documented, it can make it really easy to defend the case. So if you have a patient or family fill out questionnaires, and those are scanned into the medical record, as you review them, make notes on them, or at least initial it that you've seen it. Because they have a lot of great information in them, but sometimes people have them fill them out and then they don't even look at them. So if you miss something, you know, it can be difficult. We really recommend that you use an interpreter and not allow family to interpret for the patient. One, they may not know how to interpret medical terminology, right? They may not know how to convey that to their loved one. They may be embarrassed to ask specific questions about their loved one. They may protect their loved one and not want to give specific information. So protect yourself and your patient's right to informed consent, and use an interpreter whenever possible. If there is documentation discrepancies, you know, something that you've previously documented, now it's changed, or there's conflicting documentation, you want to make sure that you're making a notation on why. And then patient disposition, the discharge time, the patient's condition at the time of discharge, any follow-up instructions. And, you know, if you are talking to the next transition of care, maybe it's a skilled nursing facility and you talk to them, document who you are providing report to. Telephone encounters. So maybe you are doing a follow-up telephone call, or maybe they're calling in with questions. There should be a date and time of the call, who the patient's name, the name of the caller. If it's not the patient, what's the urgency, the reason for the call or complaint. And then if you have any references used, you know, maybe there's a triage form that you look at to determine whether or not you need to talk to the physician or you need to talk to somebody else about the care of the patient. The treatment plan, any clinical advice given, any acknowledgement of patient understanding, any acknowledgement for the need of callbacks. So if you're recommending that they go to the ED, make sure that they know the risks if they choose not to. If a return call is planned, make sure that there's a callback number and that any callback is done on that same note. So it closes the loop. It shows evidence of follow through. Follow-up instructions. So discharge instructions, there should be recommended follow-up that is clearly defined, time and action specific. So if your organization doesn't make those appointments for patients before they leave, they really should. Patients are much more likely to follow through on their care. Diagnoses on those instructions. Sometimes if there's more than one, there can be conflicting information, right? One might say to have a fluid restriction and another part might say to push fluids. So making sure that there's no conflicting information. There should be an accurate and clear medication list. So follow-up instructions is huge in making sure that the patient can care for themselves when they leave. So encourage patients to ask questions and repeat instructions as they understand them. If education's not generated from the EMR, we encourage that to be uploaded to show evidence. You know, sometimes things come from the CDC And, if it's uploaded, it shows what was given to them at the time. Maybe there's a video that you use for teaching, just documenting the name of the video, but make sure that there's no contradictions in the record. Now, asking for teachback. Using teachback is huge. So when researching health literacy, the Agency for Healthcare Research and Quality found patients only retain about 30% of what we teach them. But when you use teachback, they retain 60 to 70% of what we teach them. So you're not trying to feel like you're testing them. It doesn't take much longer, but you can say to them that you want to be sure they have understood what you have gone over and that they know what to do. So, I'd like to make sure I was clear about the side effects of taking this medication. Can you please explain to me in your own words what you need to watch out for? Or we've gone over a lot of things. Just so I know I've explained things clearly, can you tell me in your own words what you heard me say? This can mean the difference between your patients being readmitted to the organization or being successful in caring for themselves at home. So use teachback when you are educating patients and their family. Documenting patient education. Patient able to correctly teach back high protein diet, or demonstrated ability to dispense correct dose of medication. So Open Notes gave a couple of recommendations to improve understanding. The first is including patients in the note writing process. So patients are going to read your notes. They're getting more savvy. They're becoming getting access to the portal. So explain that the notes are about them. That they're used to communicate across the healthcare continuum. Confirm the accuracy of their medical history. Right? When I said, if you copy and paste from somebody else's note, make sure that you're going through that with them. Ensure patient understands the plan. Discuss the importance of the test or the consult or, anything. One thing is that they have access to test results, pathology reports, things like that before a provider does. Let them know that they don't need to look at the portal. They can wait until they get the call, or, telling them what the worst case scenario is, but what's expected, but here's what the worst case scenario should be. So they're prepared that they may have a diagnosis of cancer or something. And then depending on when you're doing your documentation, if there's something that you're going to be documenting that might be controversial, talk to them about it. Give them a heads up. If there's a question about domestic violence, talking to the person about their abuser and whether or not they have access to their portal, you may decide together that you're going to block that note from being released to protect the patient from the abuser seeing whatever it is that you're documenting. And then talk about the benefits, right? It helps them remember the plan. It gives them the reason for their tests or procedures. It allows them to be part of the team. Address patient inaccuracies in the medical record. So right now, patients are identifying, right, when things are incorrect, or they're reading a note and they're saying, that isn't true. This might say, I'm only active once a week, but I exercise 5 days a week. I disagree. Well, if it's something real, they identify something that's in error, go ahead and fix it. Remove whatever the inaccuracy is. If it's not real, you don't make them go through medical records and putting in that formal request and you have 30 days to fix it. Just fix it. But if it's perceived, let them know that while you can't change your documentation, you can add to the chart that the patient disagrees and their comments. It doesn't have to be anything lengthy, and it can really help your patient feel more empowered and part of the team. So we've gone over a lot of information. So here is a recap of risk management documentation recommendations. So the first and foremost, know the policies that govern your documentation, right? You want to correct your errors properly and promptly per your policy. The other thing is document as close to real time as possible. You're going to capture the most robust information. Record the sequence of events accurately, make sure to read your entries before signing, right? I don't know how many of you go to hit it, send a text message, and then you read it after you send it, and there's autocorrect. Now, medical records don't do autocorrect, but sometimes you might get, you know, you might get interrupted or something, and it doesn't reflect what you really want to say. So just read it before you sign it. Document all changes in the patient's condition and responses to treatment. So as you are going through your assessment, you're updating your care plan, there should be documentation of follow through. Now, provide a rationale for not following a treatment. You know, is there something that you're supposed to be doing and you're not? So was it that the patient wasn't on the unit? Is it that the healthcare proxy person, did they refuse to have certain treatment or recommendations, or did the patient refuse? Make sure to record the facts of an incident in the medical record, but make sure to never document that an incident report was completed or risk management notified. If you have a paper document, that there is a date, time, and signature for any written entries. You want to make sure to avoid language that expresses frustration with your colleagues, providers, patients, or their families. If using copy and paste or copy forward, ensure only relevant information is included. You want to include patients in the note writing process, right? Prepare them for the possible results of or the importance of the recommendation. And then making sure that there's documentation of their informed consent or informed refusal discussions, and partner with the physicians. If you don't think the patient really truly understood, have the provider come back and have another conversation. You want to avoid language that expresses frustration with colleagues, providers, or patients. Document objectively, avoid assumptions and opinions. Know the standards of care in your area of specialty and follow them. And then remember that the patient's chart is the best evidence of the care that you provide. Now, I'd like to end with this. And I know that it has absolutely nothing to do with documentation, but your best defense is really a good rapport with your patients and their families. So from your own perspective, if someone causes you harm, are you more likely to sue somebody who cared about you and treated you with respect and dignity, or somebody who was dismissive, took no personal interest in you, and treated you coldly? So I like to tell this story because I think it's a really good example of how a relationship or somebody's personality can help prevent it. So my husband had an injury at work, had gone to express care, urgent care. They referred him to a orthopedic surgeon. The office had a breakdown in communication. They didn't call. He ended up developing a really significant infection in his finger, into his tendon, tenosynovitis. It's an emergency. Called the office. We're going to get him in the morning, but we had to go to the ED. So the ED saw him, didn't do any imaging, gave him IV antibiotics. Of course, I'm a nurse, so I outlined everything with Sharpie, right? The infection was receding, good response. We go to the orthopedic surgeon. We see a PA. They don't do any imaging. They think that a conservative approach is appropriate, even though we said that we heard a pop. 3 months later, long story short, he still can't move his finger. They do a surgery. His tendon had actually ruptured, but because it wasn't identified, now it can't be repaired. 4 surgeries later, he's out of work, you know, for like 6 months, has pain issues, fingers are locking up, all kinds of things. He's angry, wants to sue everybody and their brother. But the surgeon is compassionate. She goes to him and says, I'm sorry, we should have looked at this sooner, you know, and she is has a great relationship. So 2 years later, even though he was angry and just wanted everybody to pay, he's like, yeah, I'm not going to sue her. She didn't mean anything. You know, it's not like she maliciously did it, but it was because of the relationship and the respect that she showed him, that he's not looking for a lawsuit. So think about that as you care for your patients and you incorporate the relationship with the family. You really can protect yourself just based on your relationship. And with that, we have time for questions.
All right, I'm waiting. There's nothing in the chat yet, Amy, but I would like to thank you for your support today and for that amazing amazing lesson that you just gave us all, and the ending for showing compassion being the most important. So if we want to wait a few minutes for questions, wait a few minutes, but I'm not sure if we'll have any.
I usually have a lot of questions, so don't be too quiet and not ask anything.
Well, and I just want to say, you know, we are new at Maine Health, at Midcoast Hospital in particular, to being on a medical record that everybody can see. So that has really been an adjustment for us when we're documenting, because patients can see what you're documenting, and they do call, they get angry, they want things removed from their records. So it's definitely something new for us.
And I think it's new too for providers to be able to be empowered to fix things real time, right? Instead of making patients go through that formal process, which
Right.
just makes them more angry because it's wrong, right? Just fix it.
Well, I don't think any of us want to be judged based on whatever the situation is. You know, there are 9 sides to every story. That's what I always say.
And I'm the
Right.
last one, right? So people are
You
probably
are
ready
the
to...
last one. Thank you again for being part of today. And we really appreciate your support and all of your pearls on documentation.
Well, it looks like Becky Weeble says, I have a question.
Looking, oh, hold on. She says, you're right, I have a question. And then somebody else said, great presentation. Do you know if the standards for overriding the rule of allowing notes that patients can see? So,
right. And I can actually see the questions. So
okay, good.
So she's asking if the standards that allowing notes that patients can see are standard in all EHRs. I don't, but the final rule of open notes and information blocking is pretty clear on what somebody can block and what somebody can't block. And so there can be some pretty heavy fines if things that, if it can harm a patient, then they say, like with the abuser, they say that that can be blocked. Psychotherapy notes are always blocked, but just because somebody has mental health issues that are documented or something to that effect, that's not allowed to be blocked. And it's actually shown that the more information that patients have, especially if you let them know that it's what you're documenting and why, it can actually help them be more of an active participant in their care, and they have better outcomes. Any advice for using the overrides? Can you be more specific on what type of overrides? All right, I see another one. I worked with a social worker that had a patient call back angrily asking her to remove something from the record. She did, but what is the right answer? If what is written is inaccurate, making a note on why it's being removed and that the patient has requested it. So if it's an error, then absolutely. If it is something, though, that they're just unhappy with how it was written, or they don't agree with your assessment, you can say that the patient disagrees and add whatever information they want to clarify, but you don't always necessarily have to remove what they have. But there's also nothing wrong with removing it, just making a note on why it was removed, being objective. So Amie, are you able to clarify or expound on the advice for using overrides? Oh, I override sometimes because certain patients are paranoid and take things very literally. Okay, so you're talking about information blocking, making it not accessible to them. Look to see what your organization's policy, they are very specific on what can be blocked. And some people block a lot of things, but that's problematic. If you may want to just look at how you're documenting, right? If it's objective, and talk to them about things that you are going to write about. Talk about open notes and give them a heads up. And you may find that they're more receptive if they know what is coming. But you want to know what your organization's specific policy is, because you may be outside of what they allow. And know that, I mean, even though you're blocking it from the portal, a patient can still go to the health information and request a medical record, and it's going to be released to them. So the only thing you're blocking is that immediate release, but they still can get it in a hard copy if they want it. I hope that answers your question. Any other questions? Yep.
All right. Thank you again, Amie.
You're welcome. Well, everybody have a nice day. Thank you for inviting me.